Buenos días. Antes de poder dar inicio, agradecemos su presencia a este webinar de Universidad Cardionovo. El día de hoy nos acompaña Michael Craven, Claudio Lina, Paolo Silvestri y los doctores Mercedes Guerra, Michael Lichtenberg, Eugenio Stabile y el doctor Deloose como moderador. El día de hoy, en colaboración con Universidad Levet, nos presentan el topic Lower Limb Management During COVID-19, What is the Role of DCB, The European Experience. Las indicaciones para los asistentes son las siguientes. En la parte superior de su pantalla encontrarán unos iconos. Uno de ellos es un signo de interrogación. Si durante la ponencia tuvieran alguna duda, pueden agregarlas dando clic en el icono mencionado. Al finalizar la ponencia, se dará respuesta a cada una de ellas. We appreciate your assistance in this webinar of Cardiovascular University. Today, we have the participation from Levitt University and Michael Craven, Claudio Lina, Paolo Silvestri, and the doctors Mercedes Guerra, Michael Lichtenberg, Eugenio Stabile, and the Dr. Delouse like moderator. Today, in collaboration with University Levitt, we present you the topic Lower Limb Management during COVID-19, What is the role of DCB, the European experience? The instructions for the audience are, if you have a question in your screen, you can look at question button. Here you can write in, and when the topic ends, we will answer all your questions. Welcome to this webinar. Now, I give the microphone to Paolo Silvestri.
Okay, hello to everybody, and thanks for participating to this important webinar. In Cardionovum, we strongly believe in supporting this kind of initiatives and to discuss and to present the clinical data. So we thank all the speakers, Dr. Guerra, Dr. Lichtenberg, Professor Stabile, and our moderator, Dr. Delouse, for their availability. We also would like to thank LabBet for their collaboration in organizing the webinar and for the technological support. So I now wish you to enjoy the webinar and leave the word to Dr. Delouse. Thank you.
Thank you very much, Paolo, for this kind introduction, and also from our part, the physicians, we would like to thank Cardionovum for the support, having this kind of educational webinars, and of course also the technical team that makes it possible to organize this in an efficient way. I think the topic of today of this webinar is extremely interesting. We as interventional specialists, we were confronted, I think, the last 2 years with two major issues. First of all, and I think everybody remembers this very well, we had January 2019, actually December 2018, where the paper of Katsanos was published, creating some, let's say, disturbance and confusion in the endovascular world concerning paclitaxel-eluting devices and the safety issues around. This was repeated 1 year later for CLI patients. So again, a publication where it was shown, or it was a statement that paclitaxel-eluting devices are also toxic and dangerous for our CLI patients. Beside of this, we were confronted with even a bigger and a more serious issue, the COVID-19 pandemic infection. So worldwide, there were victims everywhere about this infection and this pandemic tragedy. So 2 tragedies in 2 years is probably a little bit too much, although I'm sure that with the support of the companies, the engineers, the scientific world, we as physicians will be able to overcome these 2 issues. And this is the topic of today of this webinar. It's combining a little bit the 2 issues. How can DCBs, paclitaxel-eluting devices, how can they play a role even in difficult times like we encounter now the COVID pandemic infection? So, and I want to share with you the European experiences. I'm very honored to have a fantastic group of speakers from all around in Europe here during this webinar, and it's my biggest pleasure and honor first of all to introduce you Dr. Mercedes Guerra from Spain. So she's going to take the words on good practices in daily challenges, how to deal with the COVID-19 patients, and what is the role today of DCP despite the Catalanos publications. Please, Mercedes, the podium is for you.
Thank you, Cohen. Thank you, Radio Novel, for your kind invitation to share this afternoon during the special summer, COVID summer. And when the next, please. When the Katsanos meta-analysis appeared, it was a very worrying period for all society. Next, please. Before, Paulo. Yes. And in this time, in June 2019, our society, the endovascular chapter of Spanish Society, decided to publish a report from the Spanish health regulatory authorities about the use of the paclitaxel devices. The next, please. From our society, we disagree with different affirmations in the meta-analysis. As you know, there were 28 randomized studies speak about mortality in 5 years, 2 years of follow-up, but only 12 with 2 years follow-up and 3 studies with 5 years of follow-up. And the same effort for different devices was assumed, drug-coating balloon or drug-eluting stents. Next, please. And different doses of paclitaxel and excipients were very mixed into the meta-analysis, and no causality between paclitaxel and long-term death. Next, please. And the mortality was in the first endpoints in these studies. There was 11% of critical ischemia. There wasn't any distribution of mortality between critical ischemia and claudicants, different causes of mortalities, high global percentage of hypertensive smokers or dyslipidemics, and there was a very high variability around diabetes from 21 to 71%. For this reason, our society decided to publish this report in a healthcare journal on February 2019. We say that the conclusion of Casano was hasty. We should not create an alarm about it without first review the meta-analysis methodology and establishing causes that explain why the paclitaxel this relationship. And for this, it's essential to have the date of each patient and the influence of difference in health programs and follows between the different countries that may also influence the mortality rate. Finally, obviously, we need long-term effects or long follow-up for these studies. And the final messenger was prudence from our society. Next, please. At this time in June, FDA panel was done, and the conclusions was we have to see what is the risk and the benefits for our patients, and it's a very good possibility to give this option with a paclitaxel device in a specific group of patients. It's very important to give these technologies in patients with high risk for restenosis, and it's possible in these patients they need repeat femoral-popliteal interventions. Next, please. At the same time appeared the recommendation from United Kingdom, and in the first step you can see the recommendation to don't use the paclitaxel in claudicants patients. Next. In this way, the General Spanish Society say these rules to practice and say the same recommendation. Don't use the paclitaxel in claudical patients. Again, the endovascular group disagreed with this recommendation. Next, please. And we are agree with recommendation from United States. Next. And again, we did a new report from authorities, and we say that there is a sign of mortality in relation to paclitaxel that cannot be related in terms of causality. This requires the close monitoring of patients in whom this technology is applied. All clinical trials with this technology must collect, say, data for at least 5 years. This device has demonstrated efficacy and efficiency in patients with peripheral artery pathology. This is a point. The last point is different from United States. We thought that warning patients of these doubts could lead to the creation of an unproven alarm and create uncertainty in the patient. In this sense, it should be the health authorities who establish the procedure to follow up in our country. Since in international studies, this is mandatory to include this information in the informed consent. The next, please. Finally, when we through this topic had gone cold. Next. Next. So it appeared. Next, please. And again, we thought that it's necessary to do a new report with recommendation for vascular science in Spain for treating our patients in COVID era. And for in this sense, the line on emergency surgeries, for example, in asymptomatic carotid stenosis, endovascular treatment of claudicans, varicose vein disease, and no delay for symptomatic carotid stenosis, critical ischemia of spleen, visceral and renal ischemia, bleeding emergency, and urine aortic with fast growth aortic dissection, complicated head rings, and at risk hemodialysis access or infection emergency in diabetic foot. Next, please. So we have had to change the care of our patients during this period. New technologies have been developed rapidly. Again, we make a new report for the rest of the surgeons in our countries about the application of the new technologies in consulting area and operating room. For example, in consulting areas, it was possible to the patient contact with us by video consulting or mail consulting, send us a picture of ischemic ulcers. And in operating room, many apps for assistance for medical companies, and it was possible to connect with other colleagues from other hospitals for proctoring during the endovascular surgeries, very complex endovascular surgeries. Next, please. Current use of paclitaxel device in all departments. During the COVID era, it was using these devices for critical ischemia and at-risk hemodialysis access. And now, in this period in transition area, keep using these cases and return to trials with paclitaxel device. I have to say that we believe we should offer the best and safest treatment with longest expectancies for our patients. I think that we have to give one shot to the lesion in the artery of our patients, no more than one. And this shot must be the most accurate shot. Next, please. And what will the future bring? Next. Maybe more studies with paclitaxel or long-term follow-up of this one, or perhaps more new drugs is the possibility in the future. Thank you so much for your attention.
Thank you very much, Mercedes, for this very clear overview. I see a lot of positive reactions in terms of emoticons appearing, so a very great job. Probably a message for all the participants. I'm sure that the technical staff can guide you where you can ask questions. If you look a little bit above in your screen, you see the audience question possibility. So if you have questions, remarks, points of disagreement with the presentation of Dr. Guerra, I think you can share this with us, and I can transfer these questions immediately to the speaker. So Mercedes, very nice overview. I want to ask you today, and so now beginning of July, where we know that we are in a kind of transition zone concerning the pandemic crisis. So what is the role of drug-coated balloons today? Can you already treat again claudicants, or is it still CLI patients? And if yes, only CLI patients, do you treat them above the knee and below the knee with drug-coated balloons?
We don't change the regular or normal practice in this time. We are using paclitaxel, and we reviewed our series of around 200 patients with peripheral artery, and we haven't find high mortality in all groups. And our practice is use this device. So during the COVID era, it wasn't possible to make a surgery in general, because my hospital is stopping only for COVID patients, emergencies. And in the second time, I did surgery in critical ischemia, and in these patients below the knee and under the knee, we used paclitaxel devices, trachelutin stents, and dark cover stents.
Good.
Okay.
Very clear. Very clear. So I notice also that Eugenio, you have a comment for Dr. Guerra. Please go on.
Thank you, Gon. So, Dr. Guerra, I want to thank you for having posed the attention on the fact that even at this time where we are facing the COVID-19 epidemic, we should not delay the treatment of acute limb ischemia. Because in my region, we have conducted a study in which we involved all the vascular and endovascular surgeons of the area. We are serving an area of 5 million of people. And we have noticed that the rate of amputation is doubling during the COVID lockdown. So it means that the patient were arriving at the hospital with a more severe condition, and most of the time it was impossible to attempt any kind of revascularization. So I really appreciate your comment.
Yeah, and honestly, this is also our experience here in Belgium, where we see that probably it's not doubling, but the rate of major amputation is also increased in the last couple of months. So I totally agree with these findings. Mercedes, you wanted to add something there?
Yes, I agree with you, because I was speaking about the indication of the revascularization in the same case before the COVID area. But in this time, our patients are at home a long time, no go to the emergency in a hospital, and the clinical situation, it was very high, and it wasn't possible to revascularization, and the number of amputation is very high in our service during this period.
Okay, thank you very much, Mercedes. So I think we can go a little bit more in depth on this topic, and if the thunderstorms allow us, we go directly to Arnsberg in Germany, where Dr. Michael Lichtenberg will give us an overview of the situation in Germany, the characteristics of his patients, the lockdown consequences of the claudicant and the CLI real life patients. So please, Michael, again, if the thunderstorm allows us to be direct in contact with you, go for it.
Thank you, Koen. First question, do you see my screen? Can you see my screen?
Not yet. Not yet. I see your fantastic performance, but not your screen.
Oh, that's not enough, I think. Yeah, let's try for it. Yeah, I'm sorry for the technical problems, but you know, here the Sauerland region is always a little bit different, especially in thunderstorms. So let me see. Now it should probably work. Now you can see it.
It is loading. Yes.
Then we can go for it. Okay, thank you very much. Thank you very much for the nice introduction and the invitation to Cardinovo. So my part was or is to talk about the COVID-19 impact on peripheral artery disease treatment during this very complex time. Here my conflict of interest, my disclosures. Of course, also Germany was highly affected by the COVID problem, and would like to share you some insights about the German problems. The coronavirus death rate is shown here, and you can see that many countries in Europe were highly affected by death rates. Germany a little bit more, but we also had thousands of deaths. By yesterday, these are the numbers from Germany. Yesterday, we had 195,000 confirmed cases, 9,000 deaths. Death rate at the moment around 4.6%, and there are around 181 patients so far recovered, leaving at the moment 5,000 to 6,000 patients infected by the virus. You can see that, like in many other countries all over the world, there's a difference in places in terms of the infection rate, and you can see that most of the cases are in south of Germany so far known, and in the west part of Germany. The east part is not that highly affected. You can see, as in other countries in Europe, we were affected March, April, and then it declined. We had another problem in June. As you can see here, there is a peak in June of around 1,200 new patients. And the full reason for that was that we had a hotspot within one of the largest meat factories in the west part of Germany. Fortunately, it came down now, and the infection rate is now controlled in this hotspot area. We all learned that especially older patients are affected by the virus. Patients older than 70 years on, they are highly affected in many ways by the virus. In Germany, you can see, and I think this counts for many other countries, male patients were more affected than female patients, and the reason is quite simple. Male patients have more cardiovascular risk factors, and this is maybe one of the most important factors why male patients are definitely more sicker than female patients. When you're looking at the recent publication from China, published in April this year, you can see here that this meta-analysis, which analyzed all the publications so far, clearly stated that cardiovascular disease is the main driving factor, which is important for comorbidities in patients who are infected by SARS-CoV-2. And this also counted in a special way for diabetes. So diabetic patients are on a high risk to get any complications, comorbidities with this virus. We learned, and I think this is very important, especially for us as interventionalists, that this virus causes an excessive inflammation. And this is something which directly affects our daily routine within our interventions, and I will discuss this in a second. We are talking about stasis in infected patients, platelet activation, and especially endothelial dysfunction. The more affected the patient is, the higher is the risk to get complications like pneumonia, peripheral disease like DVT, or even arterial complications. And the reason, when we dive a little bit more deeply into the inflammatory response, which the virus causes, is a decrease of tissue factor, TIFP. On the other hand, it increases inflammatory cytokines like interleukin 6 and CRP. And this then is definitely associated with complication, clinical outcomes like venous thromboembolism, myocardial infarction, or disseminated intravascular coagulation, which is also very important in the peripheral artery field. And when we are looking at some meta-analysis study overviews like this one, you can see that a lot of colleagues within China or also Netherlands, United States, France, reported on these many complications like venous thromboembolism incidents. So venous thromboembolism is now definitely in our focus, that these patients are on a high risk for deep vein thrombosis. But also the arterial side is affected, and we have now a lot of reports also for about patients who had arterial complications when they are affected by the virus. This is one of the very interesting publication done by Dr. Bellosta from north of Italy. They described a higher incidence of acute limb ischemia in patients with COVID-19 pneumonia. And you can see here that between 2019 and 2020, there was a significant increase in terms of acute limb ischemia in their high volume center. And they made a clear statement in their final conclusion. They said successful revascularization was lower than expected, which we believe was due to a virus-related hypercoagulated state. The use of prolonged systemic heparin might improve surgical treatment efficacy, limb salvage, and overall survival. So that means that we also, as arterial interventionists, need to deal with this topic and have this in mind when we treat COVID-19 infected patient. Not only the venous thromboembolism part, this is of course very important. This is one of the position papers. This is from my society. We have to talk about also about the arterial side. And the arterial side is definitely included in this pathophysiology because the releasement of thrombin is one of the cornerstones that virus causes as an inflammatory response after infection. And we know, when we go back to the pathophysiologic aspects of restenosis, that thrombin is one of the driving factors for thrombosis, arterial thrombosis, and restenosis. And this means that the hypercoagulable situation, the state of a patient with COVID infection, might interfere with our peripheral interventions, as just shown from the Italy study. And this causes questions. One of the questions would be higher restenosis or rethrombosis rate after balloon angioplasty in COVID patients because of this high inflammation situation, question mark. Do we need to fear more early and long-term complications after PTA in a positive patient? And then, of course, we need to raise the question, can we include COV-2 positive clinical negative patients in prospective arterial and venous studies any longer because of this hypercoagulation complication in such patients? This is something we definitely need to analyze in upcoming trials, hopefully. Restenosis, we know, is definitely, and this counts for every patient, especially below the knee, driven by factors like von Willebrand factor, thrombin, prothrombin, plasminogen. And this is the bridge to the COVID patient. If these patients have more von Willebrand factor, more plasminogen, less TIFP, then we definitely need to fear that these patients might have complications after PTA. So the increased thrombin formation and unfavorable fibrin clot properties occur especially in CLI patients. So if you have such a CLI patient which then is also infected by COVID, we might have a real challenging patient with a bad clinical outcome if we go for intervention. And here now some very interesting discussions started already. In some discussions, might drug-coated balloons using paclitaxel or even sirolimus interrupt the cascade of restenosis by negatively, or by affecting the process of restenosis, especially also on the hypercoagulation side, with antiproliferative substances like sirolimus or everolimus. These are very interesting questions, especially in this cycle of restenosis process. The problem is at the moment there are a lot of venous studies on the way, as you can see here. This is a snapshot of the clinical trials ongoing at the moment for evaluating complications on the venous side, but unfortunately no peripheral artery studies are so far planned to really dive a little bit more into arterial field. So at the moment we only have hypotheses dealing with complications of COVID positive patients. We learned in Germany that, like in many other countries, patients fear to come to the hospital. We started a campaign which was called "Don't Let the Virus Be Responsible for Your Amputation." As we learned in Germany, that 30 to 35% of the patient did not come to the vascular centers. So we had less admissions, and the patient showed up with more significant clinical symptoms. And to really underline this problem, to learn a little bit more, we had a look at a registry database, which we started last year in February within our society, which is a prospective ongoing registry platform for endovascular peripheral procedures, looking at the clinical outcome of the patients even after 6 and 12 months. And with this data, we hope to also learn a little bit more about the challenging situation in March and April. There are a lot of quality indicators within this record trial, which tries to give very objective data after the intervention, and especially clinical outcome of these patients during follow-up. You see the recruitment per month from February 2019 until April 2020, February 2020, this database. We have now around 2,000 patients included. You can see on average, there was the same amount of recruitment, even in March and April. But what was very interesting was to see that CLI procedures, these are interim data, increased by 30% between February and May. So this is a clear hint that patients showed up maybe too late because they were afraid to come to the hospitals, showed up too late CLI symptoms. When we are looking at age distribution within our registry and looking at our first 1,000 patients, we definitely see that we again talk about the older patients. We are talking of patients who have a lot of comorbidities, patients who have other cardiovascular problems. These are clinical characteristics of our study patients so far. Again, close to 2,000 patients, typical risk profile patients. And you can see here within an analysis till February, before the crisis started, the lesion location within these patients which were included in this registry. You see typical amount of femoral, popliteal, and below the knee distribution, less CLI patient, typical claudican patient with femoral interventions. In March to May, it changed. So far as we know, we had much more BTK intervention. BTK intervention increased up to 35% in comparison to the former times. And February 2020, we had these kind of lesion types: 63% stenosis, 37% occlusions, dealing with lesion length somewhere between 10 and 20 centimeters. Most of the lesions were around 8 to 10 centimeters, so less than 10 centimeters. This is the analysis till February. You can see here that till February, we use quite frequently in this registry drug-coded balloon, even after, as Mercedes just stated, after the Katsanus discussion and problems. But what's very interesting, in March, April, and May, there were a lot of more just POBA intervention with less stent implantation and less debulking therapy. So we draw the conclusion that patients were just quickly treated and sent home as soon as possible to really create more beds within the hospitals, to leave space for infected patients. So just treat the patient and send them home. So we have now the first data for this. The discussion, as Mercedes just stated, is also going on in Germany, and we have the same issues with our regulatory boards. And we are at the moment in the very deep into the discussion with them about including more prospective and retrospective registries. At the moment, they are not looking at any kind of registries, no prospective nor retrospective registries. They're just looking at the randomized prospective trials. And we try to convince them with the mortality and rate analysis within this paper here. Unfortunately, they didn't went into the discussion with us using this kind of paper, which is a very good retrospective analysis by Eva Freisinger and Holger Reinicke, who analyzed within the last 11 years patients in terms of mortality outcome after drug-eluting DCB procedure. And they clearly stated that the additional effect of paclitaxel drug-eluting stent was not associated with increased mortality in up to 11 years post-application. They clearly stated here in the retrospective analysis that POBA was associated with a higher mortality after 1 year, and that paclitaxel coating effect in DCB was associated with a protective effect within the first year. So even with this great data, we at the moment struggling with our official boards to really come to a different conclusion. They really state that there is a mortality signal still present. There was just a new paper released by Thomas Seller and his colleague Tanja Böhme, who did a single center evaluation of mortality following paclitaxel drug-coated balloon angioplasty. And their outcome in the single center analysis was quite the same like the big Medicare data analysis. They found that within a Kaplan-Meier plot analysis, survival was clearly in favor for drug-coated balloon instead of POBA. Unfortunately, also this data will not convince our officials to restate that there is no mortality signal. So even in patients which are up to 80 years, there was a clear signal that DCB was better in terms of survival than POBA. These data will probably not convince our officials. Coming back to the COVID topic, I would like to summarize a couple of publications which just came up looking at other countries. And this is a very interesting publication from our US colleagues who did a survey within the United States asking about the changes the COVID-19 pandemic caused. And they made very interesting findings. They concluded there have been major changes to vascular surgery practice during the COVID-19 pandemic in general. Most of the 121 attending vascular surgeons who responded are limiting resident involvement in COVID-19 positive cases. 38 have been redeployed to service other than traditional vascular surgery. So this is very important. They had to work somewhere else, like on the intensive care unit or in direct line services. 21% of the vascular surgeons do not think that they have adequate access to personal protective equipment. As they are now in the real wave of this pandemic situation, they fear that they will even have more challenges in the near future. And here you can see that the colleagues were definitely frustrated because they were redeployed in other services. They were redeployed in ICUs and could not treat even patients who had vascular problems. What was also clear within the service, like in our data from Germany and also from Italy, and I think also from Spain, elective and urgent were totally different in terms of the normal time. So more urgent emergency cases during this pandemic time. So there's a clear difference also in the United States in comparison to the non-pandemic time. Their clear statement at the end was the challenges as vascular surgeons was the trouble in decision making who and how to operate, as we are dealing with our worst situation in terms of lack of resources, including limitation of ICU beds in hospital beds, anesthesia team, nurse staff, and other levels. So that means that we definitely need to take this also in consideration and planning if there's definitely coming a second wave in the second half of the year. And this is also a very clear statement. Although endovascular procedures are highly recommended during these times, being less invasive and needing less in-hospital resources, we needed to adapt our decisions and surgical actions to the changing reality in our hospital. And I think this will definitely count for many, many of hospitals who are dealing with COVID. When we are looking at a survey within European centers, we hear a very interesting survey made by Biba MedTech, which was recently published. And this survey clearly showed also that patients with acute and subacute onset was during the last month. And this really states again that we are dealing with acute and emergent patients. Interesting is that some countries think they're coming situation. So we're talking about 248 European centers during the next 3 months. I'm not sure if this will really take place, especially if we are waiting a second wave, maybe after summer holidays in fall, we'll see. In Germany at the moment, most of the physicians are very positive to come back to normal within the next few weeks. So let me conclude. Elective peripheral intervention decreased worldwide, as just shown, less because of less patient admissions. This counts especially from Europe and the United States, as we have data here. The problem is, as shown by the US colleagues, that especially for vascular surgeon, resources are a limitation because of the factors I just stated. Clearly statement that there was an increase of emergency interventions during last weeks and months, especially more acute on chronic complications were seen. Acute limb ischemia, maybe because of hypercoagulation, was predominant. The statement from many colleagues are that less open surgery was performed, especially in terms of less hospital resources, meaning that more endovascular procedures are performed during these pandemic times. In terms of the pathophysiologic aspect, hypercoagulation in a virus-positive patient might play a future role for endovascular and vascular procedures. I think we need to deal with that in future trials and future studies. High thrombin levels, as shown, might increase restenosis rate. Drug-coated balloon may be a strategy to interrupt the proliferative cascade. Definitely no data for that, just an hypothesis. We need to set up dedicated studies to really evaluate this problem. Thank you very much.
Thank you very much, Michael, for this very nice overview. So I'm just looking if I see some audience questions. I don't see it very clear. I have only one question for you that was a little bit surprising for me, saying that you did out of your database that there was more regular POBA than other, let's say, more time-consuming treatments. Honestly, this is for me a little bit a strange way of rationale, because we did just the opposite. I mean, I used even more drug-coated balloons and efficacious drug-coated balloons because I wanted to have one single good treatment for my patient, and I don't want to see him back very soon in the hospital. So this was a little bit. We know out of the studies that Eugenio will present in a while, that when you treat the patient with a good leg flow balloon, that they are good and safe for 1 year, 2 years, and even longer, and it's done. In this way, I can keep my patients, also my CLI patients, out of the hospital. What is my personal goal? What is your comment on this?
Personally, I fully agree with you, Kun. These are the data from this prospective registry. Actually, I think one of the main driving factors are, that patients should only stay as short as possible in the hospitals. Just quick and easy interventions to really send the patient as soon as possible home. These very emergent cases, probably CLI cases with severe clinical symptoms. I think this might play a role. These are very preliminary data. We just did this analysis last week, so we definitely need to dig dive a bit more into this topic. But this might be one explanation to send the patient with a very short intervention as soon as possible home to set free more resources for the infected patients. About your comment for DCB, especially in CLI patients, I definitely agree what you said. I personally believe that even in this challenging discussion DCB time, we should do best for CLI patients with even drug-coated balloon, maybe in combination even with atherectomy debulking strategy. Still a hot topic in Germany, as we are not reimbursed in Germany for CLI BTK interventions with DCBs. This is a problem still, and this is maybe one of the reasons why DCB below the knee, at least in Germany, is not quite frequently used.
Okay, thank you very much for this clear answer. And now it's my pleasure and honor to introduce Dr. Eugenio Stabile. He's working in Italy, one of the countries that was attacked the most by this crazy virus. So I'm really wondering to hear his view, and he's also going to present some of the DCB clinical results, especially with the Cardionovum leg flow balloon, in order to have a clear overview of what we have available today. Please, Eugenio.
Thank you, Con. Thank you, everybody, for attending, and thanks to Cardionovum for the kind invitation. So I'm going to make a quick review of the data that we have today available on the clinical use of the leg flow balloon. And I would like to start with the indication of the European Society of Cardiology and the European Society of Vascular Surgery, where in the latest update of 2017, they made clear that if you have a stenosis or an occlusion on the SFA that is shorter than 25 centimeters, the endovascular approach is the targeted strategy. And if you have a longer lesion or if you have the involvement of the CFA, then you can consider surgery, but pending that you have a good vein, and they're not recommending anymore the prosthesis graft. Together with this recommendation, the European Society of Cardiology and the one of the vascular surgery, they recommend to use drug-eluting balloon or drug-eluting stents. A kind of recommendation that is mirrored also by the American guidelines that appeared on the SCAI consensus back in 2018. Now we know that we had some problems in using drug-eluting balloons, starting from the meta-analysis that was published by the group of Katsanos. And to my idea, the study that provide us a good answer to the possible negative or positive effect on mortality of the drug-eluting technology is coming from the huge work that was done in Germany, in which they collected a huge number of patients, almost 65,000 of patients that were treated with endovascular procedures in the last years, and they found that there was no signal of mortality. As Michael was saying, we need now to have prospective studies, because retrospective studies cannot be enough to convince our regulatory offices, but I think that we are now in the good way. So, for the ones that still believe that we need to use drug-eluting balloons in order to avoid to see our patient back in the hospital too soon after the intervention, I just want to make a quick introduction on the technology that is at the base of the leg flow balloon. The concept is that we are dealing now not with a coating that is crystallized like sugar, that can be visible and can have bad mechanic properties, but we are dealing with a new kind of coating that is molded like honey and has more elastic ability to keep the drug on the surface of the balloon. The macroscopic appearance of this is that when we see old balloons coated with the whole technology, the first generation technology, we can see that they are like dipped in a powder, and this powder can be taken off during the tracking of the device to the target lesion. On the other hand, when we see this new generation balloon, it's really quite difficult to appreciate the presence of the coating because it's completely transparent, and also the crossing profile of the balloon is smaller. So this is the balloon that we are dealing with. It's the leg flow balloon from Cardionovum. It's a new generation balloon with a new generation of drug-eluting technology that is the safe packs, that is able to release the drug in the vessel wall and minimize the embolization possibility of the drug. So, together with some colleagues from Belgium and from Bulgaria and Italy, we conducted, as a PI center in Napoli, we conducted the first registry in which we evaluated the role of the leg flow balloon in treating SFA lesions. A total of more than 100 patients were enrolled, and we have to see that it was equally enrolled among the centers, but we have some peculiarities. Apart from the fact that the lesion length was a little bit longer than the one observed in more popular registries, like the one of the IMPACT SFA that was conducted in Italy, we decided to include all-comer patients, and this get the result that we included 43% of the population with critical limb ischemia. And as you can see, these data are now more applicable to the kind of population that we are seeing in these days also in Italy, in which we are performing the vast majority of our procedure in patients with critical limb ischemia. At 1 year, the results were quite good, both in the if we consider the overall population, if we consider instant restenosis or instant restenosis, and even if we consider CLI patients, claudican patients, and even if we categorize the patient according to the kind of lesions. Now, if we compare our results in terms of TLR, we can see that they are pretty similar to what was observed in the Illuminate, in the Italian SFA registry with the IMPACT, in the Levant from the Lutonix. But the big difference was in the fact that we are treating 2/3 of the population as critical limb ischemia. And as Michael was underscoring, these are patients with a higher hypercoagulable state and with a higher inflammation state, and are more prone to restenosis. We tried to give an answer also in terms of mortality, and we found out that there was almost a 5.7% mortality rate, and no one of the deaths that occurred between between the index procedure and the 1 year follow-up could be related to the use of the balloon. As you all know, when we try to consider the outcomes in terms of TLR, our outcomes get worse and worse with the coming of the time. And so all the studies that were tested have seen a reduction in TLR with the increasing of the follow-up. So we try to see which patient could be followed up to 2 years in our registry, and we found out that the original 120 patients, we could see 70 patients from Antwerp and Napoli. These are all the patients enrolled in the two centers that were followed up to 2 years of follow-up, and we could see that pretty much there was similar results in terms of freedom from restenosis as observed by duplex, and especially in terms of clinically driven TLR. And these are results that could be highly reproducible independent from clinical and lesion characteristics, because the results were quite good both in claudicants and in patients with CLI, and both in de novo and in restenotic lesions. If we dig into the kind of inclusion criteria, we could see that even in this extended registry that could be followed up to 2 years, the number of patients with CLI lesions was really at least 5-fold higher than all the other studies. The lesion length was a little bit longer, and also the incidence of occlusions of the SFA was much higher. And this is something that should introduce us the concept that was taken by Cohn and his collaborators, in which they analyzed how the balloon was performing in the real life. So in the Elective registry, we found simple lesions. Now, in the real life, it's something different, because we know that we treat patients with lesion lengths more than 10 centimeters, that most frequently are occluding, and they have severe claudication. Pretty much these are the lesions that are at risk of restenosis, as is indicated by the FDA. And this should be the lesion in which we should use drug-eluting balloons. So these issues were dealt in the study that was conducted in Belgium and in Germany with the name of ReFlow, and pretty much the investigator had to be complimented, because they were able to include de novo lesion with a lesion length that was longer than 15 centimeters. The study was methodologically perfect, because despite the fact that it was a registry, it has the core lab ultrasound, and this made all the results that we are discussing highly reproducible and reliable. As you see, these patients have long lesions, so we should expect that they have a robust incidence of atherosclerotic risk factors. The mean lesion length was 22 centimeters. Well outstanding was needed in a third of the patient. Two-thirds of the lesions were classified, and almost half of the lesions were occluded. They analyzed also the 1-year mortality rate to see if there was any effect from the balloon, and they found here is the list of the causes of death for the events that occurred, and out of the 95% of survival at 1 year, none of these events that caused death of the patients could be related in a reasonable way to the use of the drug-eluting technology. In terms of efficacy, safety was good. In terms of efficacy, we also should be happy, because we have a 70% freedom from restenosis clinically, freedom from restenosis at 1 year, and this was mirror, and 66% at 2 years. And this was accompanied by the fact that only one patient out of 5 came back in the cath lab after 1 year, and only one patient out of 4 came back in the cath lab after 2 years. So definitely this is a good way to make a primary prevention of restenosis. And there's results that are comparable to those available from more well-known study, that like the durability, in which the investigator tested the effect of regular stents, and also were comparable with the data observed in the Silver Pass, where it was tested both stents, drug-eluting stents, and bypass. So the DCB used in the reflow were had exactly the same or even superior results when compared with all the other strategies, and they were definitely better than bare metal stents. This was at 1 year, and this was also at 2 years, where we don't have the results of the bare metal stents, but we have the results of the drug-eluting technology. And in terms of freedom from coming back to the cath lab, the results are pretty similar to DES and seems to be superior to bypass graft. Now we need to, we are trying to get more data that are coming to the real world. We would like to set up, and we have set up, a registry that we call Elective 2. And this registry has the aim to collect information from the real world practice. We would like to enroll more than 500 patients, at least from 10 different centers, and we would like to evaluate clinical driven revascularization at 1 year. We need this because we need to know how our balloons are performing in the clinic practice. And this will drive research opportunities for all the investigators that are involved, because we will have the possibility to evaluate short and long-term data in terms of efficacy, in terms of safety, in terms of identify which are the procedural and clinical predictors that can increase the likelihood of restenosis. And we have created a CRF that will collect also information on the drug therapy that will be prescribed and will be followed by this patient after the revascularization. Because as you can see from the literature, there is an increasing interest in the kind of therapy that is prescribed to patient that undergoes revascularization. We know from the Euclid trial that all the patients that undergo revascularization after the enrollment had a bad outcome in terms of cardiovascular outcomes, not only in terms of limb-related outcomes. And so we need to make a record on how we are treating with our patient, besides the treatment that we are doing in the cath lab. So I thank you for all your attention, and I will be very happy if the most of you will decide to be enrolled in the Elective 2 registry, because we need the help from physicians worldwide. Thank you very much.
Thank you very much, Eugenio, for this amazing overview of this clinical program. So I think there is just a little place for a question. I've noticed one question of our participants, and it's for all of you of the panel. So the patients with COVID-19 positive disease, after you treated them, what was your strategy of anticoagulation and antiplatelet therapy? Was this uniform like before the pandemic crisis, or did you adapt something there, probably on the venous side and on the arterial side? So open for your comments, please.
So if I can, I could start. Basically, the decision that we are taking in the department is really dependent on the kind of picture that we can see at the angiography. Because if we are treating a patient that has a clear evidence of atherosclerosis, then we will prescribe a double antiplatelet therapy. Instead, if we are treating a patient in which we don't see much atherosclerosis on the vessel, but we can see that there is a clear thrombotic cause of the ischemia, then we will try to approach a DPI. So we will use the double pathway in which we can add aspirin to rivaroxaban 2.5 BID, and we will follow the patients.
Thank you very much. Some more additional comment from Michael or Mercedes?
Yeah, maybe for the venous side, what we clearly implemented in our clinic, and this refers to the national and international recommendation, that patients with infection, clinical symptoms are anticoagulated to prevent DVT. I think this is something most of the societies now have clearly stated, that these patients have a significant higher risk to get any kind of DVT or pulmonary embolism complication. And this counts especially for patients on the ICU, on the ventilators who are affected by COVID. On the arterial side, we did not see significant more acute limb ischemia in our center. That might be the reason why that our area here was not that much affected. So we did not change our regimen here so far on the arterial side.
Okay, thank you. Mercedes, you want to add something?
Yes. Nowadays, I only make a surgery in patients no COVID, unfortunately. But when we do a surgery in positive COVID, is only in emergency situations, so in critical situations. In these patients, when there is a very high date of the risk of thrombosis or D or other parameters about it, we put the antiplaquetars, clopidogrel or aspirin. In addition, heparin, because is the level of the risk of thrombosis is very high. I indicate anticoagulation by heparin. Okay, but in all countries, the rivaroxaban or other same treatment is not covered for the public system of health, and it's very expensive for our patients. And it's at this moment is during the COVID period is a good opportunity to change this situation about the pay of these pharmacs. And when in the rest of the case, we put a double antiplaquetar and heparin, prophylactic heparin. And when the risk is very high for thrombosis, in base of analysis, we put one aspirin, for example, and heparin prophylactic.
Mm-hmm. Okay, thank you very much. So I think I can conclude here with some general conclusions. First of all, we've learned from Dr. Guerra that despite the Cazzano's publications, that the relative risk ratio of paclitaxel is decreasing by every study that we encounter today. This beside the fact that now in the pandemic crisis, we notice that we see, and we've heard this from Dr. Lichtenberg, we see more severe lesions, severe illness with the patients, CLI patients. We absolutely want to keep the patients out of the hospital, out of the operating theaters. So we need more efficacy. And then finally, we learned from Dr. Stabile that we have this efficacy available. We've seen fantastic data of the leg flow balloon of CardioNovum during leg depth study and the reflow study, even in complex lesions, that we meet a high patency rates and very low target lesion revascularization rates. So efficacy, we have it available. I would like to thank again all the speakers for these fantastic overviews. I would like to thank the technical support committee and of course CardioNovum for the support. And last but not least, all the participants to stay with us for more than 1 hour on this interesting topic. Thank you very much.
Thank you, Gordon.
Thank you.
Thank you.
Thank you to all.
Thank you.
Buono, grazie mille a tutti.
Thank you, everybody. I guess everyone is online, and thank you for your first level speech and for your time.